So today we are going to talk about telehealth technology. It's such a wide subject. My name is Archit Bhatt. I'm one of the telestroke directors and a neurologist with Providence Brain and Spine Institute, and in Oregon here, right, office is right here. Telehealth technology is such a vast subject. It's just so hard to cover it in like 30 minutes or 35 minutes. But I'll just do my best to give you an overview of what telehealth is and what the scope of telehealth is and why we are doing it. So if you survey patients, how many patients would prefer virtual care over face-to-face care, for everyday visits. The surveys reveal that about 70% of patients would be okay with virtual care. Okay, 70% of patients prefer actually virtual care as to face-to-face care if they had to see a doctor, for a variety of reasons, right? It's convenient. Most of what we do in virtual care is communication. Most of the visits are communication. There are some visits which are complicated where assessment is part of the visit, where the physician has to touch the patient and examine the patient. But most of the visits are actually communicating diagnosis, treatment, refills, tests. So 70% of the visits and 70% of patients, they say, hey, this is fine with me. I don't mind not driving to the doctor if they are on a video. By 2025, there will be a shortage of physicians and also mid-levels, I would say, significant by 140,000 physicians will be short. And we will have to come up with a creative way to actually mitigate that shortage. And it's very onerous on the system to create more physicians. It takes 4 years for college and 4 years for MD, and then you have residency, and then you have fellowship. Just lots and lots of years. So you will have to be creative to use your existing resources and to mitigate that physicians shortage. So telehealth can help us do that, in a variety of different ways. Let me give you one example of how we are trying to do that here in Oregon and also on the system. So this was a patient I saw, I would say 2 weeks ago. And this patient presented at an outside hospital, very small, tiny hospital, a rural hospital. He was 26, completely healthy. He was a ranger. He was working. Suddenly he came home, and wife was an ED nurse. And wife was sleeping when he came home, and he woke his wife up, and he said, I'm having some difficulty in walking. This just started a few minutes ago. And the wife, who was a ED nurse, she was, post night shift, and she woke up and she said, and she started asking questions. What else are you having? And soon she realized that not only he was having difficulty walking, he was also having difficulty in speaking. And she drove him to the ER in that small, tiny hospital. And in the ER, by the time he came to the ER, he was completely unresponsive. Okay, he's 26, no medical problems, nothing really happened in the last few days or weeks leading up to this event. Suddenly started having these symptoms, pretty dramatic, and was probably weaker on one side, on the right side compared to the left. We got a CAT scan of the brain, the non-contrast CAT scan, which is not here, but we got a CAT scan which did not show any bleeding in the brain. So we decided to give him a blood thinner, which is known as TPA. So the way we traditionally evaluate these type of patients is bedside, right? In this case, this patient was like 300 miles away in a small, tiny hospital who doesn't have any access to a neurologist. So what we use is telestroke technology, and technology is essentially a sophisticated cart or robot, if you want to say, and it allows you to interact with the patient. It allows you to zoom in, allows you to communicate, and allows you to work with the nurse and the physician to examine the patient. And you can essentially make most of the stroke diagnosis using that. It's very straightforward. And you have the physicians have ability to review the scans, and the scan was the second set of scans we obtained, so let me just point it here. So if you look here, there is a white artery going up, that's the basilar artery, and there is an empty space right here, and that is a big clot in his basilar artery. Typically that artery supplies the brain stem in the back of the brain, which is a very critical aspect of the patient's brain, and if not treated, the mortality is around 80%. So in his case, he got the blood thinner, and then we immediately transferred him to a center where you can actually extract the clot. So when he was transferred over there, he was already improving by the time he reached the center, and when they did an angiogram to see the clot, to take it out, the clot had already dissolved with the TPA. So he was fortunate. He was one of the 20 to 30% of patients who the TPA like really worked, and it dissolved, and he was discharged in 2 days without any deficits. So he's a young guy. Obviously we want him to do well, but he was lucky that he was able to do that. This is possible with a highly specialized physician using technology in a small center who would never have telestroke physicians, right? So if this is telehealth works more with cognitive specialties like psychiatry, neurology, counseling, translation. I don't know if you guys work in the hospital, but they do translation, or you need a Chinese translator, or you need a Vietnamese translator. It's cognitive, right? It's your brain helping somebody else. So you don't have to touch the patient. You're just making sure visually you're making all the diagnosis, all the assessments, and you're making specific treatment recommendations. Stroke is very different because it's very high impact, right? It's not just two heads talking, but you're making treatment decisions right there when you're using the technology. So it's high impact. So moving away from the case scenario, I would like you to see this. This is a graph of two technology companies, and the technology companies, and if I move forward, so of course if this is the red graph which is going up, the revenue of that company is going up, and if you look at the blue line, the revenue of that company went down significantly and went bankrupt in 2010. Okay, and these two companies are basically Netflix and Blockbuster. So it's not that they are both good companies. They have the same product. They sell movies and shows and entertainment, but very different approach. One has a very convenient approach, that's Netflix. You don't have to leave your house. You can just watch it at any device, any screen, any time, without having to return the DVDs. So the convenience piece is a big piece here. And Blockbuster, they had the same set of product, but they just the delivery didn't. Delivery was very inconvenient. You actually had to go to a Blockbuster store every week or 2 weeks to exchange the DVDs, which was fine until you have something that disrupts that business. And what's happening right now, especially in the stroke setting, and even in general, if you look the way the care is delivered, is the patients are demanding more virtual care for variety of reasons, and there are a lot of companies trying to disrupt the traditional model of driving in 30 minutes to your doctor and having a 5-minute conversation and coming back, so what's happening is a lot of companies trying to disrupt this, and I think we are fortunate that Providence is taking this seriously. So this is a Blockbuster store in Bend, Oregon, and this is the last surviving Blockbuster store still existing there. So they still own it. They just have it for this, legacy purpose or whatever. But they still have DVDs in it. You can still exchange DVDs. I was recently in Bend, and they still have the store. This is the last one. Yeah, and if you look at Netflix right now, and if you look at, so it's not only competing with movies, right? Now it's going into shows and entertainment, and if you looked at the Emmy Awards yesterday, they got like 11. They got as many Emmy Awards like HBO, right? So they are like an entertainment company now, more than just a movie streaming platform. So and the reason they were able to do this successfully is because they have the virtual platform to scale that, and that is, it's a learning point for us, is because if you have the right platform and right technology, even in healthcare you can scale that technology in different specialties, acute care, non-acute care, outpatient, inpatient, and use it to improve quality and reduce costs, and of course give access to the communities who don't have access to. So this is a this is a photograph. This is we're discussing where healthcare is going right now. So right now what happens is when we are delivering care to the patients, we are actually trying to focus on the things that matter, which are in front of us, and we try to if a patient's having a problem, we're going to try to do that. We're trying to resolve the issue which is in front of us. We don't look what the big picture is, especially in healthcare, right? And when we look at the big picture, we have to understand that there can be bigger problems if we ignore the small problems. Are just going to be so relative to the big problems we need to fix right now. We need, when someone's having a stroke, I don't want to worry about whether they are whether they're 26 or whether they're 88. You have to focus on the diagnosis, and you have to treat those patients equally. So cost of healthcare, if you look at the United States, and the cost of healthcare is very high, and these are all the 11 countries which are all developed countries, Western countries which have advanced healthcare like the US. But if you look at the healthcare spending in the US, is much high compared to rest of the countries, and there can be several reasons around it, but of course the way we deliver health is one of the reasons, and the quality of the healthcare is the lowest amongst the all 11 countries. Now one could argue how you measure quality, but still if you look at the global metrics, mortality rate, morbidity rate, we are not in the top 5, and that is a problem. We are spending a lot of money, and we're not getting the best quality out of all that. And if you look at this graph, the healthcare spending in the United States per capita has risen faster than how much people earn, their spending capacity, the GDP. And this is really concerning. So the affordability of healthcare has gone down. because the costs have gone up significantly. So Providence St. Joseph's Health, so why is it so important for Providence? Because Providence is a large organization, and from a cost and a quality perspective, we can make a tremendous impact because our footprint is really big. If you look at here, we have 51 hospitals and 829 clinics. We have 111,000 caregivers, 23,000 physicians, and 39,000 nurses. And I mean, we cover so many lives, 1.9 million this across the West Coast, so many states. We have like 7 states now from the top, like Alaska, Washington, Oregon, Montana, Idaho, Oregon, California, New Mexico, and Texas. So large footprint. So telehealth, in Providence is focused at some of the programs are at the system level, and some of the programs are at regional level. A lot of regional programs, they do innovations locally, and there are some system programs. But in a nutshell, we do around 35,000 virtual encounters per year, and total encounters would be, I would say, thousands, like I would say millions of encounters, right? So we don't do as much as telehealth, but if you see this graph, the number of virtual visits in Providence is going up every year. More and more specialties are adopting telehealth, and more physicians are adopting telehealth. It's typically a physician barrier or a business barrier that prevents you from adopting telehealth. Most patients are okay. They will do whatever is convenient for them. So we have several different express care services. This is the express care services are like, low-hanging fruit, like somebody has a cold or somebody has a really trivial condition which they don't have to go to the ER. So it's convenience, right? So you can get in at a familiar location in your neighborhood, right? So there is a virtual part of this express care too, and there is a real in-person part of the express care too, right? So this is important because bottom line is that we are making it easy for the patients to do it. We're not creating more barriers. Calling the primary care physician. Are you available? Are you not available? If you're not available, who is available, right? So all those things are not needed for low-hanging fruit. Of course, something more complex you can engage with primary care or urgent care or even ED, but for most issues, express care is really, really useful. So this one is good. I like express care. There are competitors to express care, right? There is Zoom in Portland area. So it's disrupting the traditional model, right? And so we had to compete. So we have to compete with how the markets are changing. So this is just a sample. I don't know what the exact pricing is, but the pricing can change based on what is it, an in-person visit, just an e-visit, but it compares with urgent care and primary care, right? And the bottom line is, if it's a little cheaper and convenient to go and see someone else, patients will do it, right? Zoom Care is another example. They publish their rates just on their website. You look at the rate, you put on go to the calendar, say I want to see a physician tomorrow at 10 a.m. You will be able to do that on the website, right then, and you will exactly know how much you're going to pay. So where would the patients have gone if not to express care? They would have obviously gone to urgent care or immediate care. They would have gone to their primary care physician. 12% of cases would have done nothing, and minority of the patients would do other things or go to the emergency departments. So I think that makes a big difference, right? You are giving them access to what they never had before. So the overall vision of Providence St. Joseph's Telehealth is to make it simple, accessible, and affordable. So, and that is not an easy task, right? Because you're investing in technology, and ever-changing business metrics, it's very, very difficult to achieve. But I think Express Care is a good example. Telestroke and telepsychiatry are also very good examples. Cognitive specialties, highly focused. If you look at telestroke, across the system, we have, between all the regional programs and the system program, we have 99 live sites, and we support 6 to 8 thrombectomy centers. Means we enable patients to go to advanced procedures to these centers. They have around 8,000 plus code strokes every year. So so many stroke consults are being done. Not all are done by telemedicine, but I would say around 5,000 to 6,000 patients are seen by telemedicine out of 8,000. And beam-in rate, that means what percentage do we actually see the patient with video versus just talk to the physician who is requesting a consult. So if they are just requesting a consult for a curbside, that's a different, it's just a phone consult. But when you are beaming in, you're actually doing a patient assessment with video. Telepsychiatry is, these are old numbers, but they've grown very quickly. They are less, they're high volume, but less acuity. You can wait few hours before you actually interview the patient. It's no physical exam involved. It's mostly communication between the provider and the patient. Triaging the patient, whether this patient needs to be admitted or not, hold, no hold, or go home, outpatient. What is the emergent treatment if necessary. So telepsychiatry is a very psychiatrist is one of the specialties which is extremely scarce in the country, and child psychiatry is even worse. So it's extremely scarce. So these are the states we discussed. Alaska, California, Oregon, where you have all these telestroke sites. We are ever changing these little dots, but there's so many states we cover. So what is the value of doing telestroke, right? Beyond just access, is we try to maintain very high quality of care. Also, it's not only just we try to fill in for a site who doesn't have access to a neurologist. The quality of our service is really high, and we call them within 3 minutes of the time. We are 2 times more likely to find patients eligible for TPA compared to conventional treatments, and we have a very high TPA rate of 15%. The national rate is around 5%, and the reason is because the people who do telestroke in Oregon and the system level, they all are doing it all the time. They're just doing, and they're more comfortable doing it, and they're specialized in that. So they'll be more they'll be more comfortable giving these drugs. And we have a very low complication rate, 0.5%, 1%. National rate is around 4 to 5%. So we have a very low complication rate. So quality is high. We have very good credibility. All our physicians in Oregon are certified with stroke. Provider access value is there. Best practices. Patients get the same care at St. Vincent's and Newburgh or Medford, right, from an acute stroke standpoint. Ongoing education, we try to keep patients local and not transfer them unnecessarily. So this is an example from California, pre and post telestroke data, where we increase the TPA rate, the endovascular treatment rate by around 50%, hemorrhage rate went down, and the door to needle times, like how fast the TPA is given, went down. So this was a 1-year experience before and after. After implementing the service. And this is a graph of an abstract which we just submitted. This is data from Oregon in a research paper. If you look here, you have the blue bars and the green bars. So these are the cases in the entire Oregon, like St. Vincent's, Providence, Portland, and all the other sites which feed into Oregon. If you look here, now we give more TPAs using video technology than bedside versus traditional phone technology. So if you look starting 2017 and even 16, we use more TPAs than, of course the TPA rate has gone up, but we definitely do more TPAs or more treatments using video technology versus conventional bedside technology. So that what it means is standard of care to use technology to evaluate patients with stroke. So, I mean, telehealth roadmap, I don't want to go to the real nitty-gritty details, but it requires, the key word here is value, and value is it's a loaded word. You need to have good quality service, the cost has to go down, the access has to be, you need to give access to the patients or sites who never had access to that service. So the value may not have a dollar amount to it, but it has to mean something to the community. It has to mean something to the system. Yeah, operations are always challenging. How to do telehealth? This is probably one of the most challenging parts. Okay, I know I want to do it. If a physician wants to do it or a nurse practitioner wants to, it's very difficult. You need protocols, clinical program management. You need something known as telepresenters, where there will be well-trained nurses who would help you examine the patient if that needs to be done. Typically, it's ED nurse or an ICU nurse, experienced, or even somebody who's trained as a telepresenter. Needs to be. So telepresenter provider training. So there's so many pieces involved in telehealth. It's not just about getting in front of the camera and start talking. That's the easiest part you do. Everything else is just how to support that infrastructure, how to deal with those challenges if something doesn't work right is the hard part. And licensing, credentialing is the toughest part of it's the longest wait time. It just takes forever to license in all these states. This is the big, all the telehealth partners, Providence and Facey and Swedish. These are all part of Providence, St. Joseph's Health, and these are all the different telehealth programs we have. And just blown. I mean, even in neurology here, I mean, we do so much. Not only telestroke and teleneurology, we do outpatient teleneurology. We in MS and epilepsy, and one of the barriers is that it's very difficult to operationalize it when the patients are so scattered. In Oregon, it's just everything's so scattered, like outside of Portland. Everything is so scattered. It's very hard to operationalize it. Where to open the clinic, how to get the patients in. But yeah, I mean, it's a pretty. If you look at the number of programs, it's a lot in Providence. These are not only one region; these are everywhere. It's the exhaustive list here.